You are in live.
Yeah. ये क्या है डॉक्टर कन्वर्टेड?
Okay.
अरे क्या हो सकता
You change some.
है? So, hello everyone. I'm Dr. Harmeet Goel taking up today's session. I hope yesterday's session was informative and I've already shared today's PDF, okay, so that you can have a printout and you can keep on adding up the content. And before I start up the session, I just want to tell you that few questions, because uh, I've been getting the questions of the NEET PG since yesterday, okay, and some of the questions I feel is important for FMG exam students also, so I will be adding up those questions here, okay. So welcome you all, Dr. Nitish, Shiva, Heman, Shubham, okay, Iqbal, Tanya. So let us just start today's session, okay. And this is again a complete revision of obstetrics, and few are the questions and 2021 FMG questions, some of the PG questions I have added up in today's session, and 2022 questions also I will be adding just to give you a confidence, okay. Obs Gyne is always a scoring subject. So the first part of today's session will include the MCQs. The second part will include the images or image based questions. The third part of this slide will include the instruments, and the fourth part of this notes, which I have typed myself, I will give you the key points, and definitely from these key points the questions will come. So it is going to be a complete revision, okay. So let us begin the question session, and I am interested in adding up some of the questions for you, okay. So I am starting up first question of today's discussion. This is obstetrics, fine. So the first question of today's discussion is, a 36-year-old female was brought to the hospital in active labor, okay. She is G5P3L3A1 with 9 months pregnancy. Her pulse rate is 110 per minute. BP is 90/50. Fetal parts are very prominent and fetal heart rate is not localized. Okay, friends, one thing, just understand, fetal heart rate not localized in obstetric question means it is a dead fetus. Fetus has become dead, okay. And she has hypotension. Fetal parts felt very prominent on per abdomen examination. Cervix is fully dilated and presenting part has gone up. What is your management? First of all, what is your diagnosis in this case? My diagnosis in this case is a rupture uterus and the lady, and with dead fetus, and lady is already in shock. 90/50 is shock. So it is already a ruptured uterus with a dead fetus. Friends, just remember, whenever the fetal parts are felt very prominent, that means uterus has ruptured, baby has come out from the uterus. So on per abdomen examination, you are feeling very prominent fetal parts. Number two, fetal heart not localized, take it a question that it has become dead, fine. And presenting part has gone up because it was down, but there was either defect in the passage or passenger. The passage is it may be a contracted pelvis, that is a bony obstruction, or there may be a soft tissue obstruction which is not clear from here. So obstructed labor can occur in multigravida because as the number of pregnancy increases, the weight of the baby also increases. Okay, so it is rupture uterus, dead fetus, as she is in shock. Immediately take her for cesarean section. Do start IV line, arrange the blood and shift the patient for laparotomy. So simultaneously I will keep on writing. So it is obstetric revision for FMG 2022 June, so that this will also be shared to you in the group and it will be shared to you in my Telegram group also. Okay, so remember, if it is BP down, fetal parts prominent, patient in shock, presenting part high up, it is the diagnosis obstructed labor, dead fetus, and this is rupture uterus. So immediately take the patient for laparotomy. Okay, even if the fetus is alive, laparotomy is what is the management. Okay, laparotomy is what is the management. Before I proceed to the second question, the question in 2022 NEET PG yesterday, because this is important for FMG. जो लोग NEET PG का पेपर बनाते हैं वो ये FMG का बनाते हैं, तो please be sure about this question. Okay, you know what is a total calorie requirement in pregnancy? This is an FMG question, 2018 FMG. Total requirement of calorie during pregnancy. Keep on writing. Okay, so the answer to this question is 350 kilocalories extra of what she's taking. Now, what is the total extra calorie requirement? It is not total, it is extra calorie requirement during lactation. So extra calorie requirement during lactation is 650 kilocalories extra. These both are FMG questions. Okay, now the question in the NEET PG 2022 NEET PG was extra calorie requirement in third trimester. Extra calorie requirement in the third trimester. So friends, in first trimester no extra calorie. In the second trimester it is 350 kilocalories extra of what she is taking. In the third trimester it is 450 kilocalories extra, and in lactation it is not 650, it is 600 kilocalories extra. Okay, so just remember this. Okay, so I am giving you an extra edge. Trimester wise अगर पूछेंगे तो आपको third trimester में you have to write 450 kilocalories. Overall, if they ask, that means it is a FMG exam question. Overall they ask, then it will be 350 kilocalories extra. If they are asking lactation, then it is 600 kilocalories extra. Next, there is an important question from FMG exam. Okay, and the question is dose of elemental iron and folic acid in pregnancy, because they are asking the basics also. Elemental iron and folic acid in pregnancy. 60 mg iron, 0.5 milligram of folic acid, 100 milligram of iron, 4 mg of folic acid. 100 mg of iron plus 0.5 mg of folic acid. What is your correct answer? So I can see majority of you have marked your answer, and I have already given you the reference. So near about this is the answer, but can you see the recommendation by WHO? It is 30 mg of elemental iron and 0.4 milligram of folic acid. But the tablet available in the market may not be containing 4 mg. So we are giving 0.5, but recommended dose is 4 mg, and this is a prophylactic dose. Now, how do you give iron and folic acid in pregnancy? So 4 mg of folic acid is given in the first trimester. This is to prevent neural tube defect. Then 60 mg of elemental iron and 0.5 mg of folic acid is given throughout the pregnancy. That is in the second trimester, third trimester, and in the lactation. Aim is to prevent megaloblastic anemia, to prevent IUGR, and to prevent abruptio placentae, and to prevent or treat the iron deficiency anemia. So what is the idea of adding iron? To build up the iron stores, because total iron needed in the whole pregnancy is 1000 milligram, 700 milligram for the mother and 300 milligram for the growing baby. Okay, 300 milligram for the growing baby. Fine. So 4 mg of folic acid is given in the first trimester to prevent neural tube defects. Important question. And once the pregnant lady reaches the second trimester, then it is 60 mg of elemental iron and 0.5 milligram of folic acid to prevent iron deficiency, and folic acid will prevent megaloblastic anemia, IUGR, and abruptio placentae. Next. So I hope it's clear to you. Now, this is an important question, and it has been asked in 2021 and it has been asked in 2022 NEET PG. So I am adding up new questions also in today's session. An intern conducts a delivery. Immediately after the delivery, the mother develops breathlessness, hypotension, tachycardia, and collapse. After delivery, if there is a hypotension, breathlessness, and collapse, and there is no excessive blood loss, so postpartum hemorrhage is already ruled out. Okay. And such presentation usually do not occur with DIC, because DIC occurs when there is abruptio or a septic abortion or preeclampsia. So neither the blood pressure is mentioned nor the tense tender uterus is mentioned. So I am not going to mark DIC as my answer. It is neither uterine inversion, because in uterine inversion, why there will be breathlessness, tachycardia? In uterine inversion, it will be a neurogenic shock which will be out of proportion of blood loss. So this finding, breathlessness, hypotension, tachycardia, and collapse, please remember, this goes in favor of amniotic fluid embolism. So patient has been delivered and the lady experiences, suddenly she has breathlessness, hypotension, tachycardia, collapse. So differential diagnosis, you will keep pulmonary embolism also. So it is amniotic fluid embolism, and differential diagnosis is pulmonary embolism also. Don't think we are writing an FMG exam and this will not come. Definitely amniotic fluid embolism is a chapter, a topic given in your undergraduate textbook, Datta. So question can be asked from you also. So It is clear-cut amniotic fluid embolism question. Can you see it has been asked in last year exam and they have repeated. So you can understand question bank के कुछ questions भी repeat हो जाते हैं. It is not uterine inversion. Uterine inversion का question ऐसा नहीं होता. Uterine inversion का question देखो मैंने डाला है. Uterine inversion का question they have asked in 2019 FMG exam. This is the way they ask about uterine inversion. A lady delivers a child and she went into shock, and that shock was out of proportion of blood loss. That means blood loss was not too much. And if you see, okay, so it is not postpartum hemorrhage. It is not postpartum hemorrhage. Fine. So patient delivers a child and went into shock, that is out of proportion of blood loss. So this is acute inversion of uterus. Okay. If a lady delivers a child and she goes into shock, okay, then you think of marking your answer as postpartum hemorrhage. Okay, are these questions clear to you? Because it is very, very important. This is very, very important. Okay, so please pay attention to the question number 3. Question number 4 you already know. Okay, so I'm coming down to the next question. Minimum prenatal visits. This is 2021 question. Minimum antenatal visits. Antenatal visits. Okay, so answer to this question is 4, and it is clear कि किसी somewhat from gynae has made this question, because according to WHO latest, they say minimum antenatal visits. Minimum antenatal visits nowadays are 8. Recommendation according to WHO is 8. So you can see in this question, WHO visits cannot be applicable, because these visits are to be according to the availability of the, this is at the peripheral health center, because when we are sitting at the hospital, the total antenatal visits will be 12 to 14. Please send someone. Okay, so I hope question is clear to you. Okay, so question is clear to you. Now, according to recent updates in MTP Act in 2021, a registered medical practitioner can terminate pregnancy up to how many weeks? Again, this is our latest question. According to recent updates of MTP Act, a registered medical practitioner can terminate pregnancy. So there is 2020 MTP Amendment Act. Yes. So the answer is 24 weeks. The upper limit has been changed to 24 weeks. Fine. So there is MTP Amendment Act 2020 20. Okay, this is a new act. First thing important for you to remember is that upper limit for MTP has been changed from 20 weeks to 24. So MTP is legal if it is done by up to 24 weeks. Number 2, in 1971 MTP Act, that two opinion of two doctors was needed when MTP was done between 13 to 20 weeks. Now, according to 2022 MTP Act, only one doctor opinion is enough if MTP is done between 13 to 20 weeks. If MTP is done between 13 to 20 weeks, which question I am writing again and again? Which question I am writing again and again? Dr. Parekh, which question I am writing? ठीक है. So some students don't know what is the difference. डिफरेंस के ऊपर भी क्वेश्चन आ सकता है, खाली 24 वीक्स नहीं पूछेंगे. व्हाट इज द डिफरेंस बिटवीन 1971 एंड 2020 ईयर एक्ट? एक तो ये है कि अपर लिमिट चेंज हो गया, दूसरा opinion of two doctors was needed when MTP was done between 13 to 20. Now one doctor opinion is enough. Now another change is two doctor opinion is needed if MTP is done between 20 to 24 weeks. Two doctors opinion is needed. Okay Dr. Parekh, no problems. ठीक है, 20 to 24 वीक्स के बीच में अगर MTP करते हैं तो दो डॉक्टर्स की ओपिनियन चाहिए. नंबर 4, इफ MTP इज टू बी डन आफ्टर 24 वीक्स, से इट इज अ रेप विक्टिम, यंग गर्ल रेप विक्टिम, और प्रेगनेंसी बियॉन्ड 24 वीक्स हो गई है, ठीक है, या फिर इट इज अ कंजेनिटली मैलफॉर्म्ड फीटस, कंजेनिटल एनॉमलीज विच इज नॉट कंपैटिबल विद लाइफ, not compatible with life, so that pregnancy cannot be continued. So what is to be done in such cases? There is a medical board which decides MTP has to be done or not. And in this board there is a gazetted officer, there is a gynecologist, there is a pediatrician, and there is a radiologist. So there is a team of 4 people and this medical board will decide. The team of 4 people and medical board will decide that MTP has to be done, ठीक है, or not. So what does this board contains? Gazetted officer, gynecologist, pediatrician and a radiologist. Fine. Number 5. Previously, a patient who was married can come to the doctor for MTP. Now, if there is an unmarried girl and there is a failure of contraception, she can also legally come to the clinic for MTP. ठीक है? Previously, this rule was not applicable to unmarried girl. It was for married. So failure of contraception in an unmarried girl, she can seek help for MTP. So this is what you should be clear about MTPs. And one more thing you should know, that consent of partner or husband not needed for MTP, and the MTP is to be kept as a secret by the doctor. Doctor is not supposed to show any documents to anybody. Okay. Next, cardiac output comes to normal after how many days following delivery? This is a latest FMG exam question. Cardiac output comes down to normal after how much time following delivery? So, what is your answer? You can write down in the chat box. Cardiac output comes to normal after how many days following delivery? So the correct answer to this question is 10 days. Cardiac output comes down to normal 10 days after the delivery. ठीक है? Cardiac output, it reaches maximum. When is cardiac output at maximum? It is immediate postpartum period. Cardiac output is maximum in immediate postpartum. Cardiac output is 70%. Then during labor, cardiac output is 60%. During pregnancy, cardiac output is 50%. So immediately postpartum, that is a maximum cardiac output, and cardiac output comes down to normal after how much time after delivery? So the answer is 10 days. So it is the latest FMG exam question. Do remember. And when does blood volume comes to normal? When does blood volume comes to normal after the delivery? Answer is 7 days after the delivery. So reference textbook is Datta. So after 7 days, blood volume comes down to normal following the delivery. Okay. Then there is another important question. BMR increases in pregnancy. Basal metabolic rate. How much is the increase? Answer is 25%. Basal metabolic rate increases during pregnancy. Answer is 25%. What are the important changes in pregnancy? This is something which is important. They have started asking questions on this. The changes that increase in pregnancy and changes that decrease in pregnancy. Remember, heart rate increases, cardiac output increases, stroke volume increases, blood volume increases, plasma volume increases, hemoglobin concentration falls, platelets fall, clotting factors 11 and 13 are decreases, blood pressure, diastolic blood pressure, mean arterial pressure decreases. Diastolic blood pressure, mean arterial pressure decreases. I have already discussed, Dr. Shilpa, about uterine inversion and amniotic fluid embolism. ठीक है? So these are important changes you should remember. There is hyperinsulinemia, there is hyperlipidemia. So you should remember all these important changes. Make a list like this. Fine? Make a list like this. Now let us continue with our next question. Pelvis associated with persistent occipito-posterior position. Name the type of pelvis in which occipito-posterior position. Occipito-posterior position is common in which type of pelvis? Okay. Occipito-posterior position. Number one, it is a malposition. It is malposition of the vertex and it is common in android pelvis. Okay, it is common in android pelvis. So this is something important. Just understand, because there are 2-3 questions on occipito-posterior position and there is a chapter in your book. Occipito-posterior, number 1, is a malposition of vertex. Okay, and it is seen most commonly in android pelvis. It is seen most commonly in android pelvis. What is android pelvis? Android pelvis is called as male type of pelvis or heart-shaped pelvis. So the distance between ischial spine, interischial distance, is less than 10.5 centimeters, and at the level of ischial spine there is internal rotation. So occipito-posterior is like this. This is occiput. Normally it rotates and delivers. But in android pelvis, it get arrested at ischial spine. So what is the management of deep transverse arrest? Deep transverse arrest. Management of deep transverse arrest is LSCS. So what happens, students? Occipito-posterior position is a malposition. 90% cases there is rotation followed by delivery. In 10% cases it gets arrested. When it gets arrested at ischial spine, this is called as deep transverse arrest and management is cesarean. So this is NEET PG question 2022. If in occipito-posterior, if in occipito-posterior, if in occipito-posterior the fetal head get arrested at ischial spine, what is your management? Yes, Dr. Parekh, you're correct. If android is not given, you will mark anthropoid as your answer. So if deep transverse arrest, नीट पीजी का मैं क्वेश्चन फिर से समझा देती हूं, इस बार जो आया है ऑक्सीपिटो पोस्टीरियर पोजीशन है. ऑक्सीपिटो पोस्टीरियर पोजीशन में इश्चियल स्पाइन पे हेड अरेस्टेड है. व्हाट इज योर मैनेजमेंट? आंसर इज सिजेरियन सेक्शन. सो ऑक्सीपिटो पोस्टीरियर में सेकंड क्वेश्चन फ्रॉम नीट पीजी इज देयर इज ऑक्सीपिटो पोस्टीरियर पोजीशन. व्हाट विल बी द मोड ऑफ डिलीवरी? Occipito-posterior, I am expecting a question in your exam also. What is the mode of delivery in occipito-posterior? Answer: you will allow a normal vaginal delivery. If occipito-posterior get arrested, then you do cesarean section. But normally occipito-posterior में आपको normal vaginal delivery करना है. In case occipito-posterior gets arrested, then you do emergency cesarean section, not otherwise. Then you do emergency cesarean section, not otherwise. Okay, next. A female has a history of cesarean section and prolonged labor. She is hypotensive. एक पेशेंट है जिसमें पहला सिजेरियन हो रखा है. नाउ उसको प्रोलॉन्ग लेबर हो गया है. That means from contraction to delivery it is more than 18 hours. She is hypotensive. Hypotensive का मतलब क्या है? She has gone into shock. Fetal heart sounds are not heard. That means it is a dead fetus. This is an FMG exam question. And fetal parts are heard very superficially. Previously the question I discussed was NEET PG. Now this is FMG exam question. This is FMG exam question. So what is your likely diagnosis? Patient is in shock. It is a dead fetus. What is your likely diagnosis? Answer is uterine rupture. Because when the fetal parts are felt very prominently, that means uterus has ruptured and baby is gone into abdomen, and the fetal head has also been receded high. So this is a rupture uterus where the patient has gone into shock and there is a dead fetus, fetal parts more prominent. So this is clear cut rupture uterus, and management is immediately laparotomy and repair the uterus. If you are not able to repair the uterus, why I'm discussing this? Because scenario is they're asking questions from rupture uterus and obstructed labor, because you will be dealing with these cases even in the peripheries. ठीक है, आप ये पेरिफेरी में भी क्वेश्चंस डील करोगे, you will be managing yourself. That is why they are asking questions like this. Now there's a 2021 important MCQ, hypertensive drug of choice in pregnancy. और पता चल रहा है कि पुराना क्वेश्चन उठा के रखा है, because what is the antihypertensive of choice in pregnancy? Answer is labetalol. Labetalol is, my friends, alpha plus beta blocker. But in this question, there is no drug written as labetalol. तो पता चल रहा है कि क्वेश्चन बैंक में से क्वेश्चन पूछ लिया है. So your answer changes to methyl dopa. Now, answer changes to methyl dopa. ठीक है. So, antihypertensive contraindicated in pregnancy is ACE inhibitors. ACE inhibitors like angiotensin converting enzyme inhibitors, which is enalapril, lisinopril, captopril. Why they are contraindicated in pregnancy? In the first trimester, they cause teratogenic effects, and in the second and third trimester, they cause placental insufficiency and fetal hypoxia. So in simple terms, ACE inhibitors you can't give in the first trimester, second trimester, third trimester. If you give in first trimester, they are going to cause congenital anomalies. If you are giving in the second or third trimester, they cause placental insufficiency or fetal hypoxia. Please check your internet connection, because I am also keeping a tablet. So you can see, I am also keeping a tablet and it is absolutely very, very clear. So you can't talk about the internet connection. I am already using a Wi-Fi connection here. Okay? So you have to check your own internet connection. Now, NEET PG 2022. Why I am again and again pointing towards NEET PG? Because question can be asked in your FMG exam too. Question क्या था कि patient is pregnant, lady is pregnant and she is in first trimester. Which antihypertensive you won't give? Which antihypertensive you will not give? Answer is ACE inhibitors. You will not give ACE inhibitors. ठीक है. Next question. Which is the antihypertensive of choice in hypertensive crisis? Again the answer is labetalol. ठीक है. So since in this question labetalol is not given, so I will mark my answer as methyl dopa. I will mark my answer as methyl dopa. Now tell me, which is maximum teratogenic anti-epileptic drug. Anti-epileptic drug which causes maximum teratogenic effect. Anti-epileptic drug which causes maximum teratogenic effect. Hydralazine, Dr. Pandya, is not preferred because it causes sudden hypotension. Yes. So the answer is sodium valproate. Now, what is an anti-epileptic drug with least teratogenic effect? Anti-epileptic drug with least teratogenic effect. Answer is levetiracetam. Answer is levetiracetam. 2019 FMG exam question. Now, what is a anti-thyroid drug to be given in first trimester of pregnancy? First trimester of pregnancy, safe anti-thyroid drug. Answer is propyl thiouracil. What is the anti-thyroid drug in the third trimester of pregnancy? Question from FMG 2019. Answer is carbimazole. Anti-thyroid drug in the third trimester of pregnancy is carbimazole. In the first trimester, it is propyl thiouracil. What is anticoagulant of choice in valvular heart disease patient? I am expecting this question. This is my guess question this time. It is going to be asked. Anticoagulant of choice in valvular heart disease patient. The answer is heparin. Low molecular weight heparin. Why? Because it do not cross placenta. So till 12 weeks of pregnancy, you give heparin. From 12 to 36 weeks of pregnancy, you give warfarin because warfarin is teratogenic. So you can give in the second and third trimester. After 36 weeks to delivery, again you switch over to heparin. Now, why you will switch over to heparin in the third trimester? Why you switch over to heparin in the third trimester? Because if you give warfarin in 9th month of pregnancy, it increases bleeding tendencies in the neonate. It will increase the bleeding tendencies in the neonate. It will increase the bleeding tendencies in the neonate. So you switch over to heparin and after delivery again you give warfarin. आप एक बार फिर से देखो, because I am expecting this question in your exam. Anticoagulant of choice in pregnancy, the recommendation is throughout the pregnancy you can give heparin because it does not cross placenta, but monitoring is not easy. That is why what we do is in less than 12 weeks we give heparin, after 12 to 36 weeks warfarin, then heparin, and again then warfarin. So this is what is the scenario. Now, all are the important indications for MTP except this is 2020 FMG exam. So what is your answer? Except condom failure, will you do MTP? Yes. Rape victim, will you do MTP? Yes. Mother having serious medical disease, will you do MTP? Yes. Large family, no. If apart from large family, twins is written, will you do MTP? No. So here the answer is large family size is not an indication. Government of India has supplied the contraceptive methods free of cost. So the public should come to the hospital to avail the facilities. So what are the contraceptives that are free and supplied by Government of India? Contraceptive methods. Number one, Nirod, that is a male condom. Number two, NACO is distributing free, that is Femidom, that is female condom. Okay? Then oral contraceptive pills, Mala N is free. Then copper T 380A is free. Then Antra. What is Antra? DMPA injection is free. Then Chaya is free. What is Chaya? Chaya is Saheli. Non-steroidal contraceptive pills. Then vasectomy is free. That is non-scalpel vasectomy. Then tubectomy and laparoscopic sterilization is free. So many contraceptives are free. You should be knowing the name of the contraceptive methods. Nirod, Femidom, OCP, copper T380A, Antra, which is DMPA injection, Chaya, which is Saheli, and vasectomy and tubectomy. That these are the contraceptive methods which are freely supplied by the government. Next, which of the following is not included in active management for third stage of labor? Active management of third stage of labor. What is your answer? Which of the following is not included in the active management of third stage of labor? Yes. So third stage of labor is very, very important for questions. Third stage of labor is very, very important for questions. So delivery by controlled cord traction method is recommended by WHO. Late cord clamping or delayed cord clamping is recommended. Injection oxytocin intramuscular bolus is recommended. But uterine massage is a part of atonic PPH. Uterine massage is a part of atonic PPH. So, wrong answer is uterine massage because that is the management for atonic PPH. So, what is the active management of third stage of labor? This is important. This is every year asked in exam. Active management of third stage of labor according to WHO guidelines. Number one, injection oxytocin, which is called as uterotonics, is given intramuscular bolus after the delivery of the baby. Then placental delivery is to be done by controlled cord traction method. Placental delivery is to be done by controlled cord traction method, and there should be a delayed cord clamping. Delayed cord clamping, it means cord clamping is done within 1 to 3 minutes of delivery, so that extra 50 to 100 ml of blood from mother, it goes to the baby. And here uterine massage is not done. Uterine massage is a part of atonic PPH management. Uterine massage is a part of atonic PPH management. Okay. Now, what is recommended? This is from FMG exam. Recommended dose of folic acid in female with a history of neural tube defects in the next pregnancy, in the last pregnancy. What is the therapeutic dose? Because it is indicated neural tube defects. What you will recommend? I would say 4 mg because I don't want neural tube defects to present again. What is the ultrasound finding of neural tube defect? Answer is lemon sign or banana sign. Lemon sign or banana sign on ultrasound is a finding for open neural tube defects. Now, this is an interesting question. Which of the following conditions is the serial determination of pregnancy test? 2021 important exam question. What is your answer? Which condition, कौन सी condition में आप serial beta HCG कराते हो? Serial beta HCG. Which condition you get serial beta HCG done? Yes. Is it a molar pregnancy? Is it a viability of pregnancy? Gender identification, RH. जेंडर और आरएच की कोई सिग्निफिकेंस नहीं है. आंसर है मोलर प्रेगनेंसी. वायबल प्रेगनेंसी के लिए सीरियल अल्ट्रासाउंड की बिल्कुल भी जरूरत नहीं है. सीरियल बीटा एचसीजी इज डन फॉर मोलर प्रेगनेंसी डिटेक्शन. ओके, आई वुड से एच मोलर प्रेगनेंसी. व्हाई? Because H molar pregnancy is a trophoblastic tumor where there is grape-like vesicles and these vesicles produce HCG. And HCG, after you do suction evacuation, that is a treatment for H molar pregnancy, you do the follow-up. With serial beta HCG, because once you have taken out these grape-like vesicles, the source of beta HCG has been reduced and beta HCG should show a falling trend. So beta HCG becomes negative after 3 to 9 weeks of suction evacuation. So follow-up for 6 months is needed. So how do you do the follow-up? Weekly beta HCG till negative for 3 weeks, followed by monthly beta HCG till negative for 6 months. Monthly beta HCG till negative for 6 months. Now, if there is a patient of H molar pregnancy and she is on follow-up, or you have a patient of choriocarcinoma, she is on follow-up, the patient must use contraception. Now, what is the choice of contraception in trophoblastic tumor follow-up patients? कौन सा contraception आप recommend करते हैं trophoblastic tumor के patients को? Which contraception you recommend to a patient who is trophoblastic tumor follow-up? Answer to this question is oral contraceptive pills. You will not advise beta HCG, and copper T is contraindicated. Any genital tract malignancy, copper T is contraindicated because copper T can cause perforation and copper T can cause bleeding. So copper T is not recommended. Okay. Next. Maximum amniotic fluid at what period of gestation? Latest FMG exam question, and the reference I am going to take up from the Williams, and please remember 32 weeks. Although the textbook Datta is writing 36 weeks, but I am going in favor of 32 weeks because here I would like my students to take the reference from Williams textbook. This is important. So I'm expecting this question in your exam. Amniotic fluid at 12 weeks of pregnancy, it is 50 ml. 20 weeks, it is 400 ml. 32 weeks, it is maximum 1 liter. So remember this question. 2021 exam. Okay, and at term pregnancy it is 600 to 800 ml. I am expecting one question at least from these two. Okay, so remember 32. Yes, Dr. Pawar has written very correct. It is 32 to 34 weeks. But one answer to select, please mark your answer as 32 weeks. Okay. Fetal kidneys. Fetal kidneys start secreting urine, and this urine becomes contributor to the formation of amniotic fluid. This is as early as 12 weeks. Fetal kidneys start secreting urine as early as 12 weeks of pregnancy. Now, a pregnant lady visits the antenatal OPD for the first time at 18 weeks and her fundal height is corresponding to 16 weeks. That means fundal height is less than the period of gestation. Obstetrician has advised an ultrasound. What will you expect? Fundal height less. First differential diagnosis will become wrong dates, that is not given in the options. Fetal anemia will be same fundal height, anencephaly will be same fundal height. So it is oligohydramnios, and oligohydramnios, the important cause is bilateral renal agenesis. So it is oligohydramnios and it is bilateral renal agenesis. Now there is another important question. Have you heard about a condition called as Doppler ultrasound in pregnancy? Yes. Tell me single most important indication for getting a Doppler ultrasound. Answer: single most important indication for Doppler ultrasound is if there is an IUGR. Second important indication is patient having preeclampsia. Third important indication is chronic hypertension. So what do you see in Doppler ultrasound? Basically you check the diastolic blood flow pattern in umbilical artery, and next is uterine artery, and third is middle cerebral artery. So अल्ट्रासाउंड डॉपलर का इंपॉर्टेंट रोल है. आप किन पेशेंट्स में कराते हैं? IUGR में मोस्ट इंपॉर्टेंट इंडिकेशन, then PIH, chronic hypertension or long standing diabetic patients. Diastolic blood flow pattern is read or studied in umbilical artery, uterine artery and middle cerebral artery of the fetus. So these three blood flow patterns are very, very important. Okay, next. 25-year-old patient, para 1 L1, delivered 12 weeks back, gives a history of continuous heavy bleeding per vagina. एक lady है, 12 weeks back she delivered, and this is the latest question. And she has heavy bleeding. 3 months back she delivered, and there is a history of DNC done. Patient was having heavy bleeding. Why DNC was done? The doctor thought there may be some retained products of placenta. They may be secondary PPH, because if up to 3 months there is a bleeding after delivery, then that goes in favor of secondary PPH. So DNC was done, but bleeding is continuing. What do you think is a likely diagnosis? Is it a postpartum hemorrhage if bleeding is continuing? Ideally, bleeding should stop after DNC. So it is not PPH. DIC will occur immediately. Why it is occurring after 12 weeks? It is not normal lochia. Lochia normal is up to 6 weeks of delivery. So she has developed gestational trophoblastic neoplasia. She has developed gestational trophoblastic neoplasia. So this is important question. Now I would say secondary PPH can occur after 24 hours of delivery till 12 weeks of delivery. Okay? But this patient is bleeding. Okay? So most common cause for secondary postpartum hemorrhage is retained bits of placenta. For that, the doctor in the private sector has done DNC. After DNC, bleeding should stop. If there were any retained products of conception, then bleeding should stop. But after DNC, why bleeding per vaginum is continuing? Why this is continuing? What is the reason? That means after a full-term pregnancy, if there is increased bleeding and it is heavy bleeding, not been stopped by DNC, then in that case, this is gestational trophoblastic neoplasia. And which type? Most probably it is choriocarcinoma. So how do you diagnose choriocarcinoma? Increased titers of beta HCG or plateau of beta HCG, or there is metastasis of choriocarcinoma. This is how you diagnose. So you can get a chest x-ray done, you can get an ultrasound done. Okay, so please just be clear about this question. If after 3 months of delivery, even after DNC, the bleeding is not stopping, that means that focus has developed a gestational trophoblastic tumor. It can be an invasive mole, it can be a choriocarcinoma, you can differentiate, but most likely after a full-term pregnancy, there is a chance for choriocarcinoma. So, beta HCG, serial beta HCG will give you raised titers, or there is a plateau, or there is a metastasis, something or the other. On the X-ray chest finding, you will find there is cannonball appearance. You can get ultrasound abdomen done or whole body CT scan to look for the sites of metastasis. And here the treatment will be after confirmation chemotherapy. Now, this is important question, and again I am expecting this question. What are the markers for triple test for Down syndrome? What are the markers for triple test for Down syndrome? Except beta HCG, alpha fetoproteins, estradiol or estriol. You can keep writing your answers, which is not a marker for triple test. So this is latest. Every exam they're asking this question. So the wrong answer is estradiol is not a marker, because estradiol is secreted by ovary. Okay. So in the first trimester screening, for Downs, we do blood markers blood markers are beta HCG and PAPA, and you combine it with an ultrasound to check for nuchal translucency. Timing for this is 11 to 13 weeks. Okay. Now, in the second trimester, you do triple test around 15 to 18 weeks. Triple test markers are alpha fetoproteins, beta HCG, and estriol, where in trisomy 21 and trisomy 18 all are decreased. Trisomy 21 beta HCG rises and alpha fetoprotein and estriol are decreasing. Now, in the second trimester, there is a quadruple test. Apart from these marker, what is added? Inhibin A is added extra and inhibin A rises. So, there is alpha fetoproteins, beta HCG, estriol and inhibin A. Okay. So, you can very well revise. So, I think you are seeing that topic after the topic I am revising so that none of the important questions are missed out, and पक्का 100% आज के डिस्कशन और yesterday's डिस्कशन आपके 80% से ज्यादा क्वेश्चंस पक्का आएंगे इसी डिस्कशन में. And in this slide I have already added the important single liners also, and I am going to share this PDF. ये दोनों जो मैं क्वेश्चन पेपर में लिख रही हूँ ये भी मैं शेयर करूंगी ग्रुप में, and the one I am writing that also I will be sharing in the question paper in the Telegram group. Next, 25-year-old primary gravida is on lithium. This is again an important question, and this I have taken it from PG. This is a PG question. So 25-year-old primary gravida is on lithium for psychiatric illness for 2 years. Most common anomaly with lithium. What will you mark your answer? This is very important question from your pharmacology as well. Is it a VSD? Is it a PDA or it is abstain? Lithium is causing abstain anomaly. Please read it in detail. Okay. Now, if the division of fertilized ovum takes place between 1 to 3 days of fertilization, name the type of monozygotic twins formed. 1 to 3 days of fertilization, what is the type of monozygotic twins formed? I am discussing question number 20 now. What will be the type of twins formed? Yes, on 1 to 3 days, it will be diamniotic dichorionic. Students, if the question is asked most common type of twins in the world, then remember 80% of all twins are dizygotic twins, and dizygotic twins are always diamniotic dichorionic. Okay. If the question is asked most common type of monozygotic twins, now they have specified. Can you read the difference? Here they have asked most common type of twins, so dizygotic, and answer will be diamniotic dichorionic. But if they ask from monozygotic, which is the most common type of monozygotic twins, your answer will be diamniotic and monochorionic. Okay. Among the monozygotic, 75% of monozygotic twins are diamniotic and monochorionic. Now, if the division is occurring within 72 hours of fertilization, the twins will be diamniotic dichorionic. If between 4th and 8th day, it is diamniotic monochorionic. If after 8th day, it is monoamniotic monochorionic. And if after 13th day, it is conjoined twins or Siamese twins. Okay. So, फिर से देखो, if they ask most common type of twins, that means they are asking among dizygotic and monozygotic. So 80% will be dizygotic. So you mark your answer as diamniotic dichorionic because that is the most common variety. If they ask among monozygotic, then your answer changes. Then your answer changes to diamniotic monochorionic. If they ask division is occurring this, then your answer will be accordingly. This all you know. Okay, next. 26-year-old female with a mechanical valve and she's on warfarin. This is again an important question. She's on warfarin and pregnancy test is positive. What will you advise? This is again a latest question from 2021 exam. Continue the warfarin throughout the pregnancy? Wrong. Replace heparin with warfarin? No. Discontinue all anticoagulants? No. Sorry, the answer will be replace heparin. What will be your answer? First trimester, what will you give? You will replace actually there is some mistake in this question. There is some mistake. Actually, you have to switch over to heparin. First trimester, you have to replace warfarin with heparin. Yes, that is what is a mistake in this question. Maybe while I was typing, replace warfarin with heparin. So the answer is you have to give heparin. The meaning is you have to give heparin. Okay? Chalo. Lady had recurrent abortions between 14 to 20 weeks. That means it is a second trimester abortion. What is the most common cause for second trimester abortions? The answer is cervical incompetence. Most common cause for second trimester abortion, answer is cervical incompetence. Most common cause for second trimester abortion, the answer is cervical incompetence. Okay, now there is a latest 2022 NEET PG question. You know, when there is cervical incompetence, when there is cervical incompetence, there is second trimester abortions. Okay, so you safest investigation to confirm cervical incompetence is your ultrasound. What do you check? You check for cervical length, and cervical length reduces to less than 2.5 centimeters. So what is the treatment of cervical incompetence you gave? The answer is cervical encerclage operation. Timing of cervical encerclage is around 14 weeks or 2 weeks earlier than previous pregnancy loss. 2 weeks earlier than previous pregnancy loss. Now, question from NEET PG was cervical encerclage. You know name of cervical encerclage? McDonald stage, Shirodkar stage. Cervical encerclage operation. This has been asked in this year INICET exam also. So आपके एग्जाम में भी आ सकता है क्योंकि नीट पीजी में आया है और INICET में आया है, तो आप भी ध्यान से सुनो. सर्वाइकल एनसर्कलाज ऑपरेशन, ठीक है. यू अप्लाई नॉन एब्जॉर्बेबल suture at the level of internal cervical os and you need to remove it. You need to remove it anytime after 37 weeks. Okay. Now, you have to remove it early. When you have to remove it early? When bleeding starts or leaking per vaginum starts or there is preterm labor pain start. Then you have to remove this stitch. Okay, so there was the latest question on this. Yes, cervical encerclage plus progesterone or any of the uterine relaxant you have to give, because patient should not go into preterm labor pains. So you might have to remove this stitch early if the leaking starts or bleeding starts or there is a preterm labor pains that starts. Now, which is the safest tocolytic agent? Which is the safest tocolytic agent? Answer is nifedipine. Okay. Then there is another important question in NEET PG on magnesium sulfate toxicity. Now remember and tell me what is the first sign of magnesium sulfate toxicity. What is the first sign of magnesium sulfate toxicity? The answer is absent patellar reflex. So if such a basic question has been asked for the PG, it will be asked for FMG students also. So please do remember this and do revise. Next, the complication associated with IV bolus oxytocin. Remember, it is the latest question. Complication associated with IV bolus oxytocin. Complication associated with IV bolus oxytocin. What is your answer? IV oxytocin you give for augmentation of labor or induction of labor, and its duration of action is 20 minutes. It is comparatively a very, very safe drug. Okay, but you never gave it IV. You students are just check the battery.
Wait.
Session end मत करो.
नहीं.
माइक दे दो. यही करो.
Hello.
Now it is okay. Is it audible now? Yes. Now next question is Gravida 4P0A3. That means this is her fourth pregnancy and she does not have any live baby. It is 3 abortions. ग्रेविडा 4 का मतलब क्या है? नंबर ऑफ टाइम्स द लेडी इज प्रेग्नेंट. P means parity. She had 3 abortions and now she is 22 weeks, and previous 3 mid trimester abortions, that is recurrent abortion, cervical length is 20. So most probable cause for recurrent abortions, what is your answer? Yes, all of you are correct. It is cervical incompetence. If cervical incompetence is not given, then I would mark uterine anomalies as my answer. It is not chromosomal, sorry, it is cervical incompetence. Cervical incompetence is the answer. Okay, so next, lining epithelium of fallopian tube, very basic question. Always the fallopian tube is columnar ciliated because role of cilia is to propel the fertilized ovum towards uterine cavity. So it is columnar ciliated epithelium. Now, 24-year-old primary gravida is having pain abdomen. Her cervix is 1 centimeter dilated, 20% effaced. After 10 hours, finding is roughly the same. So she is already in labor and the findings are same. What is your next step in management? Fetal heart is normal. Everything appears normal. What will you do? Are you going to sedate your patient? Start oxytocin, do ARM, do emergency cesarean. Has she become post-dated pregnancy? No. Is it anything that there is a sign of fetal distress? No. Is it a blood pressure which is shooting up? No. So what is this? This is simply a prolonged latent phase. And friends, management of prolonged latent phase is sedate your patient. This might be a false labor pains. So nothing to be done. It is just sedate your patient because कभी कभी normal pregnancy पे भी question पूछ लेते हैं. So this is a prolonged latent phase, and the management of prolonged latent phase is if the fetal heart is normal, blood pressure of the lady is maintained, there is no signs or features of delayed labor. So just sedate your patient. It will be the treatment. Now 24-year-old female, she is at 32 weeks of pregnancy. Blood pressure is 160 by 110. So this is severe preeclampsia. This is severe preeclampsia. Her liver enzymes are raised. Liver enzymes are raised and the LDH is elevated and there is low platelets. So what is this? This is clear-cut a case of HELP syndrome. Hemolysis, elevated liver enzymes and low platelets. So you might have to see and look towards the signs of end organ damage, and if there is any warning symptoms of headache, blurring of vision or urine output is decreasing, you might have to take termination of pregnancy. So this is clear-cut a HELP syndrome, and this is a very, very good question they have asked, but it is a question from PG exam. Okay, next, which of the following is the treatment for decubitus ulcer for genital prolapse? Genital prolapse again is an upcoming topic, and you might be seeing genital prolapse in cases of when you will be doing your internship in the hospitals. So what is a decubitus ulcer? Okay, genital prolapse. Genital prolapse is a gynae topic. Okay, genital prolapse means there is a cervical descent, there is urinary bladder prolapsing in vagina, that is called as cystocele. There is urethra prolapsing in vagina, that is called as urethrocoele. There is rectum prolapsing in the vagina, that is called as rectocoele. There is omentum or pouch of Douglas prolapsing, that is called as enterocele. Okay, so these are the types of genital prolapse. Most common type of genital prolapse is cystocele. Now, if the cervix is lying continuously outside, this is called as third degree cervical descent. Okay, so the venous return, there is venous congestion and because of venous congestion, there is formation of an ulcer at the level of cervix. This is called as Decubitus ulcer. Okay, because of venous congestion. So what is the management of Decubitus ulcer is reposition of cervix back into vagina and doing glycerin acreflavin packing. Okay, you take a tampon dipped in glycerin acreflavin solution and pack the vagina. Reduce this cervix back into the vagina. So what is glycerin acreflavin going to do? Glycerin acreflavin. Glycerin is hygroscopic. Hygroscopic means it will reduce the edema. It will reduce the cervical edema, and acreflavin is antiseptic. So this ulcer will heal and there is no emergency. अगर patient को 10 साल से genital prolapse है तो क्या हो गया यार, 15 दिन और रहने दो ना. What is the need to do an urgent emergency? So let the ulcer heal. Because if you're planning a vaginal hysterectomy and at the level of cervix you give an incision, it will bleed like hell. Okay, so you will keep on catching the bleeders and it will be difficult for you to manage such cases. So always let the ulcer heal by doing a glycerin acreflavin packing and then give a final date for hysterectomy. Okay, this is something new for you if you have not read it before. So here the answer will be packing. Okay, so all the new questions I am adding up in the session, I presume the ones which I have discussed in my classes or in the previous sessions, you have revised all that. Okay. A female after delivery complains of cramps during breastfeeding. Cramps during breastfeeding, which of the hormone is responsible? Just remember what is galactokinesis. Galactokinesis means milk ejection reflex. That means oxytocin is the hormone that acts on the breast tissue and it causes contraction of the breast and milk release. So the pain which she is feeling during the breastfeeding is just because of oxytocin. Prolactin causes milk synthesis. Prolactin does not cause the milk release. So the hormone for milk release is oxytocin. Now 25-year-old female with 8 weeks amenorrhea, slight bleeding per vaginum. On examination, the cervix is closed, bleeding per vaginum is present and size of the uterus is corresponding. But there is a fetal cardiac activity present. So this is an FMG exam question. So what is your answer? Cardiac activity present, size of the uterus same, bleeding is present. This is no other than threatened abortion because here the cervix is closed. So in this question, the cervix is closed, but the bleeding is present, but the size of the uterus has not decreased. So this is what is a threatened abortion. This is what is a threatened abortion, and you can save this pregnancy. You can save the pregnancy by giving progesterone to your patient. Okay. Next, 35-year-old female, gravida 3P2A0, 37 weeks of pregnancy. She is bleeding profusely and there is a central placenta previa at 32 weeks. So whenever there is an ultrasound after 28 weeks, you need not repeat the ultrasound because placental localization becomes fixed at 28 weeks. So whatever the diagnosis of placenta previa has been made on ultrasound, it will remain the same. It will not change. So don't be in a hurry to get an ultrasound done for this patient, even if she presents with profuse bleeding. And no need for an bedside ultrasound also, because diagnosis of central placenta previa is already made. And since this is a 37 weeks of pregnancy, so what is your next line of management? And your patient is stable. She's bleeding, but she's stable. What is your management? Management for this is immediate cesarean section. Okay. Now, I would like to take up one latest question of NEET PG exam 2022. The question is, there is a pregnant lady. She is 36 weeks and she has previous classical cesarean section done. I think she is 32 weeks and she has previous classical cesarean section done. Now she has breech presentation. Breech presentation. What is your management? She wants a normal vaginal delivery. Will you allow a normal vaginal delivery? No. Even it is a lower segment cesarean section, the management, remember, any scarred uterus with malpresentation, any scarred uterus with malpresentation in the present pregnancy, management is always an elective cesarean section. क्योंकि माल प्रेजेंटेशन में आप कोई भी मैनिपुलेशन नहीं कर सकते, इट विल कॉज रप्चर यूट्रस, और ये तो ऑलरेडी एक क्लासिकल सिजेरियन है, तो हमेशा क्लासिकल सिजेरियन में नेक्स्ट प्रेगनेंसी is always a cesarean section. That is 100% rule. There is no role of VBAC. VBAC का मतलब क्या होता है? Vaginal birth after cesarean. VBAC हम LSCS केसेस में करते हैं, बट नॉट इन क्लासिकल. क्लासिकल में हमेशा ही प्लान्ड सिजेरियन करते हैं. तो यहां पे तो माल प्रेजेंटेशन है. व्हाट इज द माल प्रेजेंटेशन? स्कार्ड यूट्रस विद ब्रीच. अगर मैं डायग्राम बनाऊं तो इसमें ऑलरेडी एक सिजेरियन हो चुका है और दूसरा बेबी जो इस टाइम है वो ब्रीच प्रेजेंटेशन में. नॉर्मली भी ब्रीच में क्या होता है? अस्फिक्सिया होता है. या हम कोई भी मैनुअर कर रहे हैं, एक्सटर्नल किफैलिक वर्जन, वो भी कॉन्ट्राइंडिकेटेड हो जाएगा. ठीक है, तो ये तो क्लासिकल सिजेरियन स्कार है, क्लासिकल सिजेरियन सेक्शन स्कार जिसमें ब्रीच प्रेजेंटेशन है, तो इट विल बी अ प्लान्ड सिजेरियन, नो अदर आंसर. तो ये क्वेश्चन क्यों एफएमजी में नहीं आ सकता? यू टेल मी वन रीजन. कितने नए क्वेश्चन लाएंगे वो? कुछ तो पुराने क्वेश्चंस भी पूछेंगे या फिर जो लेटेस्ट पीजी में पूछे हैं. द सिलेबस फॉर यू इज द सेम. सो any scarred uterus with malpresentation and breech is the most common malpresentation. तो प्रेजेंटली उसके यूट्रस में क्या प्रेगनेंसी है? ब्रीच प्रेजेंटेशन है. तो अगर हम इसमें कोई भी मैनुअर करते हैं, ठीक है, तो उसमें रप्चर यूट्रस हो जाएगा पक्का. इसमें हम कॉन्ट्रैक्शंस अलाउ कर ही नहीं सकते पेशेंट को, बिकॉज क्लासिकल सिजेरियन द चांस ऑफ स्कार रप्चर इज 4 to 9%. Okay. And nowadays also, if it is a LSCS, trial of labor is given even only in the institutional deliveries. ठीक है. So concept based questions मैंने डाले हैं आपके लिए. जिन लोगों ने अच्छे से पढ़ाई करी है वो इस पेपर को आराम से सॉल्व करेंगे. जो लेटेस्ट पैटर्न चल रहा है आपके एग्जाम का, आप देख रहे हो 2018, 19, 20, 21, 22, मैंने रीसेंट एग्जाम के क्वेश्चंस डाले हैं, मैंने पुराने क्वेश्चंस डाले ही नहीं है. बट सिंगल लाइनर्स देखो आप, यू शुड बी सेटिस्फाइड. सिंगल लाइनर मैंने आपको ऑलरेडी दे दिए हैं, इससे ज्यादा क्या करोगे यार? अब टीचर की जान लोगे क्या? ऑलरेडी सिंगल लाइनर्स भी हैं. दोज हु आर इन फेवर ऑफ सिंगल लाइनर, देखो कितने सारे सिंगल लाइनर्स मैंने टाइप किए हैं. ओके, so these single liners I am going to give instruments, I am going to give you in the content, image based questions, latest questions, PG, FMG. So it is a complete preparation from my side. I have done my work and I have done my hard work to give you the maximum possible latest content, and it's for you to revise now. So let's just quickly go through so that timely we should finish up this session and no question should be left undiscussed. Okay, next, a lady has delivered a child and she went into shock, and this is out of proportion of blood loss, so it is acute inversion of uterus. I have already discussed. Assessment of progress of labor is best done by, assessment for progress of labor is best done by So it is done by partogram. So the best assessment of labor is done by partogram, and there are 5 components of partogram. I will show you in the image. Now, management of third stage PPH. What is the third stage PPH? Third stage PPH means the baby has delivered and it is whole placenta is retained. Okay, placental separation has not occurred, so there is retained placenta. In this case, you have to do manual removal of placenta under GA. So this was a question of FMG, and latest question they have asked in this NEET PG 2022. The question in NEET PG is, a doctor was conducting a delivery. Delivery was conducted, and while removing the placenta by controlled contraction, umbilical cord got torn. Umbilical cord टूट गया. What is your next management? आप क्या करोगे? You will take out the placenta in the labor room. What you will do? Doctor was conducting the delivery, or the staff was conducting the delivery, and placenta was being removed by controlled contraction. I like the answer of Dr. Vishnu. The management is manual removal of placenta in OT under GA, because if you forcibly try to take out the placenta, you will land up in another complication that will be acute inversion, and you can't put your hand into the uterus to take out the placenta because umbilical cord has been torn. So management of this latest question. अब आप देखो, आप लेटेस्ट क्वेश्चन के आंसर्स कर रहे हो, एंड इवन यू आर सॉल्विंग पीजी क्वेश्चंस इन माय सेशन. सो दैट विल बूस्ट अप योर कॉन्फिडेंस कि मैडम ने पीजी के क्वेश्चंस भी डिस्कस कर दिए हैं, INI-CET, नीट पीजी, लेटेस्ट FMG एग्जाम क्वेश्चंस, all the possible content, and you should make me happy by marking all the questions correctly. तो पीजी क्वेश्चंस भी तुम सॉल्व कर रहे हो, साथ साथ स्मार्टली मैं पीजी भी ऐड करे जा रही हूँ, और FMG questions I am discussing already. Formula used to calculate EDD from LMP is Neagley's formula. From LMP to EDD, it is 280 days. So you add 9 months plus 7 days to LMP. You will get the expected date of delivery. This is Neagley's formula of EDD calculation. Now, a female has undergone IVF and injection HCG was given to trigger the ovulation. She has nausea, vomiting, headache, and ovary looks like in this image. इमेज में डालना भूल गई हूं, मैं आपको इमेज दिखा देती हूं. क्या इमेज है इसमें? What is the image looks like? Image, by chance I forgot to give you the image, तो image भी दिखा देती हूँ मैं. क्या इमेज थी आपके एग्जाम में जो आई है? इमेज वॉज, व्हाट इज द इमेज? सो ये क्वेश्चन FMG में भी आया है, PG में भी आया है. व्हाट इज दिस इमेज शोइंग? फटाफट बताओ. The HCG injection was given, ovulation induction was already done. Please do not mark polycystic ovarian disease as your answer. Your answer will go wrong. It is not polycystic. Polycystic ovaries में peripheries में cyst होते हैं, इसमें तो पूरा multiple cysts बन गए हैं. This is because of hyperstimulation of ovaries, and I am happy my students are writing the correct answers. Which is a drug which is causing ovarian hyperstimulation syndrome is HMG injection, that is FSH injection. HMG injection, that is FSH injection. So the answer to this question is ovarian hyperstimulation syndrome, and ovarian hyperstimulation syndrome is a complication. Okay, ovarian hyperstimulation syndrome is a complication. So the answer to this question is ovarian hyperstimulation syndrome. Next, which conjugate we can clinically measure? Which conjugate we can clinically measure is a diagonal conjugate. We can measure diagonal conjugate. Now, a neat PG question. Which of the following is an absolute contraindication to breastfeeding? Can you tell me? Herpes simplex virus, galactosemia, CMV, or hepatitis C virus in the mother? You know from your biochemistry classes, galactosemia is a contraindication to breastfeeding because baby will not tolerate. Intrauterine pressure in the third stage of labor is 100 to 120 millimeters of mercury. Oligohydramnios is seen in renal agenesis because the fetal urine is a main contributor to the amniotic fluid. Classical triad for congenital rubella are all except. This is again a neat PG question. Which is not included in the classical triad for rubella? Answer is renal agenesis is not included. Congenital cataract, deafness, cardiac anomaly. What type of cardiac anomaly is PDA? Patent ductus arteriosus. What is the cutoff? What is the cutoff value for plasma glucose for screening? Answer is 140. So glucose challenge test nowadays it is DIPSI criteria. Diabetes in Pregnancy Society of India. So 75 grams of glucose is given and the blood sugar is checked after 2 hours. So its cutoff value should be less than 140 milligram per cent. All are the risk factors for preeclampsia except which is not a risk factor for preeclampsia. So the answer is multiparity is not a risk factor. APLA means antiphospholipid antibody syndrome. APLA means antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. A lady at 16 weeks of pregnancy presented with bleeding per vaginum. Cervix is open. When the cervix is open but products have not expelled but there is bleeding. So this is called as inevitable abortion and the management is DNE using the ovum forceps. All are the risk factors for placenta previa except primi gravida is not a risk factor. Parity more than 5, previous curettage, previously scarred uterus are the risk factor. So it is a disease mostly in multigravida, not the primi gravida. Next, best marker for intrahepatic cholestasis. This is very much an FMG exam question. Intrahepatic cholestasis is an important cause of jaundice in pregnancy, but it is mild jaundice. Liver enzymes are raised and the marker is bile acids. Okay, marker is bile acids. All are true about obstructed labor except which is not. Bandel's ring is seen, true. Hematuria, true. Fetal distress, true. Bandel's ring is a physiological retraction ring, false. Bandel's ring is a pathological retraction ring. So the answer is D. It is pathological retraction ring. It is pathological retraction ring because physiological retraction ring is present in all the females. Which of the following is not recommended in heart disease in pregnancy? Which is not recommended? Cut short the second stage of labor by forceps or vacuum. This is recommended because if you allow a normal delivery and there is a prolonged labor, it will lead to CHF. So this is done. Oxygen should be given by mask. This is correct. Prophylactic antibiotics is given, yes, because we don't want to spread any infection to the heart, but IV methergine is not given because it will increase the chance for congestive cardiac failure. Already there is so much of cardiac output which is maximum in the immediate postpartum period. If you give methergine, it will cause strong contraction of uterus, pushing all the blood to systemic circulation. So lady will precipitate congestive cardiac failure. External cephalic version is contraindicated in all except in breech presentation. You will do external cephalic version. What is external cephalic? Baby is in breech presentation or baby is in transverse lie. You are shifting the lie to vertex externally because you don't want to do a cesarean section for breech or transverse lie. So the indication for this is breech presentation. Twins, ruptured membranes, APH, these are all the contraindications to external cephalic version. Sequence of lochia during purpurium. What is the duration of lochia? What is the duration of lochia? Lochia is 3 weeks. So the sequence is lochia rubra serosa alba, RSA, rubra serosa alba, and duration of lochia is 3 weeks, which is not a contraindication in pregnancy, which is not contraindicated. What will you mark? Valproate, propyl thiouracil, radioactive iodine or warfarin. So propyl thiouracil is safe, it is not teratogenic. Valproate causes teratogenic effect, iodine causes teratogenic effect, warfarin causes teratogenic effect. Okay, so all these are contraindicated drugs, whereas propyl thiouracil is safe. A woman was referred from PHC with prolonged labor. She is now being taken for LSCS for fetal distress. What is the correct position for LSCS? This I have already told you. Supine position. This is an FMG question 2019. Supine position, putting a wedge under the right hip, because if there is a compression on the inferior vena cava, in maximum cases, 90% cases, the paravertical collaterals or azygous collaterals open up, but in 10% cases, if it does not open up or it fails to open up, lady develops hypotension, breathing difficulty, etc. So we put a wedge under the right hip so that inferior vena compression can be avoided. All of the following are the causes of coagulopathy. Coagulopathy means DIC except. So the wrong answer here is placenta previa do not cause DIC. Accidental hemorrhage, that is abruptio, eclampsia, amniotic fluid embolism, and septic abortion. These are the causes of DIC, but placenta previa, bleeding is there, but it does not cause any DIC. Now, 28-year-old female with 6 weeks amenorrhea pain. She has empty uterus and mass in the adnexa. She fainted. Caldosynthesis was done and the blood was aspirated. So this is a ruptured ectopic because uterus is empty and there is some mass in the adnexa and she fainted. Clitoris is derived from genital tubercle. Urogenital sinus gives rise to lower vagina and urinary bladder. Genital ridge gives rise to ovary. Genital swelling gives rise to labia majora in the female. Okay. Drug to be given in case of raised intracranial tension in pregnancy. Question from FMG 2016. So the answer is mannitol, because you want to reduce the cerebral edema. You want to reduce the cerebral edema, so you give mannitol. Anti-epileptic drug with least teratogenic effect, levetiracetam, I have already discussed. This is 2019 FMG exam question. It's already been discussed. Please pay attention to this. And a lady presented with 6 weeks and she has an adnexal mass of 3 centimeters and small gestation sac and fetal node, but not the fetal heart activity. So it is clear-cut ectopic pregnancy and it is unruptured. So it fits into my medical management. Please do read the criteria for giving a medical management, and the drug given is methotrexate. Okay, less than 3 centimeters, cardiac activity absent. This is clear cut an indication for medical management for unruptured ectopic pregnancy. Hormone responsible for desensitization is progesterone. Amniotic fluid at term pregnancy is 600 to 800 ml. I've already discussed this. On per abdomen examination, the maneuver done to check for the lie and presentation. What is your answer? Maneuver done to check for the lie and presentation is Leopold's maneuver, and you know the grips also. Best fetal parameter to find out period of gestation in the first trimester is CRL. Otherwise, dates or LMP is 100% accurate method, but they have not given the dates, so I will mark CRL in the first trimester. All about beta HCG are correct except it is a lipoprotein. This is wrong. Beta HCG is a glycoprotein. Alpha is non-specific, correct. It is beta which is specific. Peak level is 60 days, correct. It has immunosuppressive activity, that is also correct. Most common compound presentation, important FMG exam. Compound presentation means more than one part is presenting. So it is always head with an hand like this. Shoulder presentation is a term. Remember, shoulder presentation is transverse lie. For macrosomia, what is the term used is shoulder dystocia. Difference क्या है? Shoulder presentation में shoulder ही सबसे पहले deliver होता है and leads to obstructed labor. Shoulder dystocia में shoulder ही deliver नहीं होता, head gets stuck up. So that is a difference between this. Please do revise this. Beeline sutures are applied in uterus for atonic PPH. Most common cause of secondary PPH, retained bits of placenta. That can be succinturita lobe of placenta. Rate of descent of fundal height following delivery is 1.25 centimeters in 24 hours. They have asked a question in NEET PG, what is the descent of fundal height on second day? So answer is 4 finger breadth. 4 finger breadth. Okay. Weight of the uterus immediately after delivery is 1000 grams. Weight of the uterus does not change. In 6 weeks time, it will revert back to 60 grams. Which of the following is preferred treatment after the birth of baby in an hepatitis B positive mother? So answer is you need to give active plus passive immunization. That means you will give vaccine as well as immunoglobulins, but the site of injection should be different. If one injection is on the right leg, another should be on the left leg. Anti-thyroid drug in the first trimester is propylthiouracil. Mullerian inhibiting substance in utero is secreted by Sertoli cells, and after puberty in the girls it is secreted by granulosa cells. Bishop score is to evaluate the cervical status before the induction of labor. Management of eclampsia includes all except which you will not do in case of eclampsia. Control of conversion, true. Control of BP, true. Delivery of fetus, true. But prolongation of pregnancy is not done because we want immediate termination of pregnancy. So we will do the delivery. How frequently fetal heart rate is monitored in the partogram? It is monitored every 30 minutes in the first stage of labor. Landmark for pudendal block is ischial spine. Precipitate labor is when first and second stage of labor is shortened to less than 3 hours. To induce ovulation in galactorrhea plus amenorrhea, it is bromocriptine which is preferred. Ovarian hyperstimulation syndrome is most commonly caused by HMG because it is directly stimulating the ovaries as it is an FSH injection. Okay. Now let's quickly have a look at these images. What is this maneuver in this image? This is an image-based question being asked in FMG exam. So the grip is a lateral grip which is being applied. That is a second grip. Okay. And this maneuver is a Leopold's maneuver. And the grip is a second grip which is applied. That is a lateral grip. Next. This is the maneuver you can study from this image. First grip is a fundal grip, second is a lateral, third is a Folic grip, and fourth is a pelvic grip. Okay. Components of partogram you can study. First is maternal information, second is fetal well-being, third is a labor progress, fourth is a medication, and fifth is a maternal well-being. This is important. You can study from this. I'm already shared this PDF in my group Telegram. Now, what is this maneuver? Where baby is shown in the transverse lie and the doctor is putting the hand into the uterus and taking out the legs. So, this is internal podalic version. This is done for second baby of twins, transverse lie. Only indication for internal podalic version. It is done under GA in OT. Second baby of twins, transverse lie. What is this instrument? Question being asked in FMG exam. Answer is Babcock's 2020 FMG exam. This is Babcock's to do tubal ligation. Deep transverse arrest occurs in android. Question from FMG. Identify the type of sterilization. This is Pomeroy's technique. And which part of the fallopian tube is removed? Is ischemic part of the fallopian tube that is removed. What is this conjugate which is shown in this? It is a diagonal conjugate, although this is the image based question asked in DNB PG exam. Now what is this image showing? This is a reactive non-stress test which has been showing. What is this image? This is anencephaly. What do you see? This is a frog eye sign. This is a frog eye sign. 25-year-old female comes with 2 months amenorrhea, and what is this sign? Where uterus is felt between two examining fingers. This is Hager's sign. Usually checked at 18 weeks. Correct answer is 6 to 10 weeks. Now there's a diagram of lactation you can go through. Sometimes they ask on the various hormones, not just the same hormones. 2020 FMG they have asked growth hormone is also responsible for mammogenesis. So just go through this physiology of lactation just to know what are the associated hormones that is responsible for mammogenesis, galactopoiesis, galactokinesis apart from the main hormones. This is Cocker's forceps. This Cocker's forceps in obstetrics is used to perform ARM. So it is very important step in cases of accidental hemorrhage. It accelerates the labor, and this is called as surgical method of induction of labor or augmentation of labor. This is Valsalm. This is to hold the cervix. This is Alice tissue forceps. I have already discussed. This is Carman's cannula. This is Leash-Wilkinson cannula to inject dye into the uterus during hysterosalpingography. This is outlet forceps, Wrigley's, and we apply outlet forceps at +2 station or below. This is Ayer's spatula to perform pap smear. This is Carman's syringe or MVA that is for medical regulation. This is Vire's needle for during when you introduce a trocar and cannula and laparoscope. Vire's needle is used first. These are the single liners. Uterine artery is a branch of anterior division of internal iliac. Ovarian artery is a branch of abdominal aorta. Treatment of Bartholin abscess is incision and drainage. Bartholin cyst is marsupialization. Relationship of ureter to uterine vessels is posterolateral. What are the muscles attached to the perineal body? Bartholin duct opens. Structure homologous to prostate gland is glands of Skene. Structure homologous to Bartholin gland is Cooper's gland in the males. Now living ligature is present in the middle layer of uterus. Sequence of branches of the uterine artery in the uterus is ARBS, arcuate, radial, basal and spiral. Weight of the uterus during pregnancy, according to Williams, total weight gain during pregnancy is 12.5 kg and weight of the uterus, gravid uterus, is 1 kg. And weight gain during pregnancy of the female is 12.5 kg. Cardiac output is maximum immediate postpartum. Iron requirement during pregnancy is 1000 milligram. There is a gestational thrombocytopenia, hyperinsulinemia occurring in pregnancy. Breathing movement occurs at 11 weeks. Now, what are the structures derived from 3 germinal layers? Parts of the decidua, okay. And raised ICT drug is mannitol. Status eclampticus. The drug given is thiopentone sodium. Steps in the active management of third stage of labor includes this. Uterine massage is not a part of this. It is delayed cord clamping. So wrongly typed, please make a correction. It is a delayed cord clamping. Cardiac output comes to normal in 10 days after delivery. Rate of involution of uterus is 1.25 centimeters following delivery. Okay. So which is the best tocolytic? Nifedipine. Gold standard for endometriosis is laparoscopy. So all the best for your exam. It's for complete revision of gynae and obstetrics, and I want your full marks in obs and gynae. And stay connected. I will guide you for the UPSC CMS exam. You can watch my videos on the YouTube also, so you can follow me. You can stay connected with me on Facebook or Telegram. I am on Instagram and I have my YouTube channel and WhatsApp group. So these are my social media sites. You can stay connected: Facebook, Telegram, Instagram, YouTube, and presently I am like in as a gynecologist. I've joined the Rajiv Gandhi Cancer Institute, Rohini, and I am into teaching also, taking classes. So all the best for your exam. Telegram link I have already been sharing since yesterday, so I will share this PDF also. All the best and see you in bright colors. Okay, wherever you want my guidance for your career, I will definitely guide you. Okay, so bye bye and all the best for a great future ahead. Thank you very much.